Hey everyone, today I'm going to talk about substance related and addictive disorders. We're going to talk about ways to understand the etiology or the why and the diagnostic process or the what through a trauma informed lens. So let's start with a question. Why do people use substances or engage in compulsive behaviors like gambling, excessive shopping, or even workaholism? The common answers might be because it feels good, because they lack willpower, or because they're chasing a high. But what if I told you that for many people, substance use isn't about pleasure? It's about survival. When the brain has been shaped by trauma, substances or compulsive behaviors can feel like the only way to cope, the only way to regulate emotions, or the only way to find a sense of safety, at least temporarily. And that's why today we're not just talking about substance related and addictive disorders in isolation. We're looking at them through a trauma informed lens, asking not just what the addiction looks like, but why it developed in the first place. To connect today's discussion to what we've already covered, let's revisit the role of trauma in mental health. Trauma isn't just a bad experience, it's an event or a series of events that overwhelm a person's ability to cope. It changes the brain, particularly areas like the amygdala or the fear center, the hippocampus or the memory, and the prefrontal cortex or that decision making part that lives right at the front, right behind your forehead. And this rewiring can lead to hyperarousal, like constant fight or flight mode, emotional numbness, or extreme difficulty regulating emotions. And many people with unresolved trauma turn to substances or compulsive behaviors to quiet their nervous system, numb emotional pain, or momentarily escape distress. If we don't account for this in how we diagnose and treat addiction, we risk missing a crucial piece of the puzzle. So before we go further, let's define a few key terms. Substance related and addictive disorders include both substance use disorders like alcohol, opioid, stimulants, and behavioral addictions, though currently only gambling disorder is recognized in the DSM-5-TR. So sometimes we'll differentiate those by talking about substance addictions and process addictions. And these disorders are not simply about how often somebody uses a substance or engages in a behavior, or whether they're doing it socially or not, but it's about loss of control, compulsivity, and a significant life impairment. Next, trauma refers to an experience that overwhelms a person's ability to cope, whether it's a single event like an accident or a prolonged experience like childhood neglect. Trauma informed care is an approach that recognizes how trauma impacts the brain and body and seeks to create a safe, empowering, and collaborative treatment environment. So instead of asking, "What's wrong with you?" we shift to asking, "What happened to you?" And that's a critical distinction in addiction treatment. Understanding addiction through a trauma informed lens is essential because it challenges the outdated narrative that addiction is simply about bad choices or weak willpower. Addiction is not a moral failing, nor is it always driven by a desire for pleasure. For many, it's about soothing an overactive stress response or numbing emotions that feel unbearable. If we only focus on stopping substance use but ignore the trauma or the pain underneath, we set people up for relapse, shame, and continued struggle. A trauma informed approach allows us to recognize addiction as a maladaptive coping strategy, one that can be replaced with healthier, more sustainable ways of regulating emotions and stress. And with this foundation in place, we're now going to shift into understanding how we diagnose substance related and addictive disorders. The DSM-5-TR and the ICD-11 offer frameworks for classifying these disorders, but they differ in some key ways, particularly in how they define harmful substance use versus dependence and which behavioral addictions they include. As we move into this discussion, I want you to consider, if trauma plays such a huge role in addiction, how do we ensure that our diagnostic and treatment approaches don't inadvertently re-traumatize the people that we're trying to help? So let's dive in. So how do we actually diagnose substance-related and addictive disorders? So think about this. What makes a behavior or substance use cross the line into a disorder? It's not just about how often somebody uses or engages in behavior, whether they're doing it socially or not. Those are pretty common myths. But whether it's controlling them instead of the other way around. And this is where our diagnostic manuals come into play, the DSM-5-TR and the ICD-11. So the DSM-5-TR defines substance use disorders based on 11 symptoms across 4 major categories. So the 4 categories are loss of control. So that would be using more than intended, unable to cut down despite wanting to, and spending a lot of time obtaining, using, or recovering from use. The second one is social impairment, failing to meet responsibilities at work, school, or in family relationships, giving up important activities like hobbies, or continued use despite relationship problems. The third is risky use, and that would be using in dangerous situations like drinking and driving or drinking at work, and continuing despite worsening physical or psychological health. And the fourth one would be pharmacological changes. So that's where we talk about tolerance and withdrawal. So tolerance is needing more for the same effect. So maybe think back to your first drink ever and a beer really got you drunk very quickly. And then maybe you needed two to feel the same effects. And then maybe you need three. And then maybe you need four. And then maybe you need 12. That's tolerance. You need more of the same substance to feel the effects. And then withdrawal is physical or psychological symptoms when stopping the substance use. And diagnosis is based on a symptom count. So when you're looking at those 11 symptoms across the four major categories, you're going to count them. If somebody meets 2 to 3 symptoms, they're going to have a mild substance use disorder, 4 to 5 is moderate, and 6 or more is going to be considered a severe substance use disorder. So again, it's not about how much or how often somebody uses, it's about how it impacts their life. So we've covered substances, but can behaviors be addictive too? And I know I already talked about the gambling disorder that's present in DSM-5-TR, and it's the only non-substance addiction that's present in the DSM-5-TR. So it follows the same structure for diagnosis as substance use disorder. So it's tolerance, withdrawal, and loss of control. It hijacks the dopamine system in the same way that substances do. But what about sex addiction, shopping addiction, social media addiction, workaholism, all of the other process addictions that you can think of? So process addictions are the things that we do that might seem addictive that don't involve substances. So let's talk about the role of dopamine and glutamate. So dopamine is the I want this neurotransmitter. It reinforces pleasure and motivation. And glutamate helps to form strong behavioral habits, making it hard to stop. So both dopamine and glutamate play a role in addiction. They play a role in substance use disorders. They play a role in the process addictions like gambling disorder too. But so if this is so prevalent, the question is, why aren't these in the DSM? Why is gambling disorder the only process addiction that's present? And sometimes asking that question leads to more questions. Is it because of a lack of research? Gambling has decades of data, but the other behaviors don't so much. Is it because of a cultural bias? We might struggle to pathologize behaviors society views as normal. For instance, workaholism. People get rewarded for working hard. I know I get rewarded. And another question might be insurance and treatment concerns. So if something is labeled as a disorder, should insurance cover therapy for a shopping addiction? So a question to consider that you can discuss here is, why do you think that gambling made it into the DSM while other behavioral addictions or process addictions didn't? Should they be included? Should they not? Should some? Should others not? Where do we draw the line? I want to bounce back to talking about severity levels and specifiers just to make sure that we really understand this. So once we diagnose a substance use disorder or gambling disorder, we're going to add specifiers to describe its stage of severity. So mild is meeting 2 to 3 symptoms, moderate is 4 to 5, and severe is 6 plus. So again, that's out of the 11 symptoms. And the symptoms are the same across the board for any substance. So you can look at substance use disorders sort of as a whole, and then in a little bit, we're going to break down each of the substances individually. But we're also going to look at specifiers here because addiction isn't static. Always going to identify mild, moderate, severe, so the severity level. And we're going to add a specifier if appropriate. And also when diagnosing, we want to add the specific substance of use too. So you might see something like moderate opioid use or mild alcohol use. So that's the language that we're using. And then specifiers get tacked on at the end. So we have something called early remission, which is 3 to 12 months sober, and sustained remission, which is 12 or more months sober. So for instance, if I had a client who was in recovery for alcohol use, maybe they've been going to AA for 14 years, but they're coming to treatment because they're really afraid that they're going to relapse. They don't meet criteria for an alcohol use disorder right now, but I do want to document that they met criteria for an alcohol use disorder 14 years ago. So I might say something like moderate alcohol use disorder in sustained remission. And that would be the diagnosis that I would give to note in their chart that this is in their past, but they're still dealing with the effects of it right now. So let's talk about why this might matter here. A person in sustained remission may not have the same risks as somebody who's newly sober, and it also helps track progress in treatment. So this is one of those diagnoses that's going to need to change and evolve over time. If you're seeing the same client for, 12 months, they're probably going to meet an active substance use disorder, then a substance use disorder in early remission, and then ideally a substance use disorder in sustained remission. And then moving on to the ICD-11, which is just a little bit of a different approach. The key differences between the DSM-5-TR and the ICD-11 are that the DSM-5-TR uses substance use disorder and it focuses on behavior. The ICD-11 has two major categories. So it's harmful substance use and substance dependence. And the harmful substance use focuses on physical or mental damage from use, while substance dependence focuses more on cravings, tolerance, and withdrawal. And the ICD-11 also recognizes gaming disorder. So that can look like the gambling disorder, But what's also included here is the internet gaming disorder or internet gaming addiction. So you're just on your phone all the time playing Candy Crush, you might meet criteria for a gaming disorder. They also add compulsive sexual behavior disorder, or what's also called a sex addiction. So the biggest takeaway here is that the ICD-11 prioritizes harm, while the DSM prioritizes behavior patterns. So the DSM-5-TR classifies substance use disorders by substance category, recognizing that different types of drugs impact the brain and body in unique ways. While all substances listed have the potential for addiction, the severity, withdrawal symptoms, and long-term effects vary across substance classes. So we're just going to break each one down individually. Starting with alcohol-related disorders, alcohol is one of the most widely used and socially accepted substances, yet it is also one of the most dangerous when misused. Found in beer, wine, liquor, and even over-the-counter products like mouthwash, hand sanitizer, alcohol is classified as a central nervous system depressant, meaning that it slows down brain function and motor skills. The effects of alcohol vary depending on dose and individual tolerance. At low doses, it can produce relaxation, lowered inhibitions, and mild euphoria. However, at higher doses, alcohol impairs coordination, distorts judgment, and affects memory, leading to slurred speech, motor dysfunction, and blackouts. Chronic, heavy alcohol use can result in severe long-term health consequences, including liver disease, also known as cirrhosis, cognitive decline, and cardiovascular issues, and neurological impairment. When an individual who is physically dependent on alcohol stops drinking, they may experience withdrawal symptoms which can range from mild to life-threatening. Mild withdrawal symptoms typically include tremors, anxiety, irritability, sweating, and nausea. However, in severe cases, withdrawal can progress to delirium tremens. That's a medical emergency characterized by hallucinations, seizures, extreme confusion, and autonomic instability. Delirium tremors, or maybe you've heard them called DTs, can be fatal if left untreated, making alcohol withdrawal one of the few withdrawal syndromes that requires medical supervision. For mental health counselors, understanding the severity of alcohol withdrawal is crucial. Clients attempting to quit alcohol, particularly those with a long history of heavy use, may need medically supervised detoxification to prevent complications. Unlike withdrawal from most other substances, alcohol withdrawal can be deadly, and symptoms should never be dismissed as minor discomfort. Counselors should also assess for co-occurring mental health conditions such as depression, anxiety, or trauma histories, as many individuals with alcohol use disorder are self-medicating underlying emotional distress. Ensuring that clients receive comprehensive, trauma-informed support is the key to long-term recovery. Moving on to cannabis-related disorders. So cannabis is one of the most commonly used psychoactive substances and is often perceived as harmless or even medicinal. However, chronic use can lead to dependence and mental health complications, particularly for individuals who begin using at a young age or have a history of trauma or psychiatric disorders. The primary psychoactive component in cannabis is tetrahydrocannabinol, aka THC, which is responsible for its euphoric and mind-altering effects. Cannabis can induce relaxation, altered perception, and increased appetite, but at high doses, it may also cause paranoia, hallucinations, and heightened anxiety. Long-term use has been associated with amotivational syndrome, where individuals experience a lack of drive, difficulty focusing, and reduced interest in goals and responsibilities. Additionally, cognitive impairment has been observed in heavy cannabis users, particularly in those who started using during adolescence, as THC impacts brain development. Beyond traditional marijuana products, synthetic cannabinoids like K2 or spice have emerged as highly potent and unpredictable alternatives. Unlike natural cannabis, these substances are lab-created chemicals that bind more aggressively to cannabinoid receptors in the brain, often leading to severe agitation, psychosis, violent behavior, and even medical emergencies. In contrast, CBD, or cannabidiol products, which contain little to no THC, are not often considered addictive and are primarily used for pain relief, anxiety management, and seizure disorders. So while cannabis withdrawal is often underestimated, frequent and heavy users can develop psychological dependence and experience withdrawal symptoms when stopping use. These symptoms include irritability, insomnia, loss of appetite, restlessness, and mood swings, making it difficult for individuals to quit despite wanting to reduce or stop use. So for mental health counselors, it's important to recognize that while cannabis withdrawal is not physically life-threatening, it can still have a significant impact on mood, sleep, and overall well-being. Many clients may not recognize their psychological dependence on cannabis, particularly if they use it for anxiety or emotional regulation. Counselors should assess for underlying reasons behind cannabis use, help clients develop alternative coping strategies, and educate them on the risks of long-term use, particularly in relation to motivation and cognitive function. And special attention should be given to young adults and individuals with a history of anxiety, psychosis, or trauma, as they may be at a higher risk for negative psychological effects from cannabis use. Moving on to stimulant-related disorders. So stimulants are a highly addictive class of substances that increase dopamine and norepinephrine levels in the brain, leading to euphoria, alertness, and a burst of energy. These drugs include illicit stimulants like cocaine and methamphetamine, as well as prescribed medications that treat ADHD like Adderall, Ritalin, Vyvanse, and Concerta. While prescription stimulants can be safely used as directed, they are often frequently misused for performance enhancement, weight loss, or recreational euphoria, especially among students and professionals. Cocaine and methamphetamine are among some of the most addictive stimulants, producing an intense but short-lived high, which often leads to binge use followed by severe crashes. Users experienced increased energy, suppressed appetite, and heightened confidence, but with chronic use, these drugs can cause significant cardiovascular damage, paranoia, hallucinations, and aggression. Methamphetamine in particular is notorious for causing severe physical deterioration, leading to meth mouth or tooth decay, extreme weight loss, and compulsive skin picking due to hallucinations of bugs under the skin. And when stimulant use stops, individuals will usually experience a severe crash, characterized by extreme fatigue, depression, difficulty sleeping, and intense cravings. Unlike opioid withdrawal, stimulant withdrawal does not typically produce life-threatening symptoms, but the psychological distress can be overwhelming, leading to relapse. For mental health counselors, it's important to assess stimulant use patterns, underlying mental health conditions, and reasons for misuse. People who use methamphetamine may present with psychotic symptoms, paranoia, or aggression, requiring stabilization and harm reduction approaches. People who use cocaine often struggle with intense cravings and depression post-use, making behavioral interventions like contingency management or reward-based incentives highly effective. Students and professionals misusing ADHD medications may not recognize their dependence and may need psychoeducation on the risks of stimulant overuse, particularly its effects on heart health and anxiety levels. And addressing underlying stressors, burnouts, or self-esteem issues is key to helping these clients develop healthier coping mechanisms beyond their stimulant use. And then let's talk about hallucinogens. So hallucinogens are a diverse group of substances that alter perception, mood, and cognition, often producing intense sensory experiences, hallucinations, and changes in thought patterns. These substances can be divided into two major categories: classic hallucinogens and dissociative drugs. While some hallucinogens are being studied for therapeutic benefits, their misuse can result in psychological distress, paranoia, and in some cases, persistent perceptual disturbances. Classic hallucinogens include substances like LSD or acid, psilocybin found in magic mushrooms, mescaline or peyote, and DMT or ayahuasca. These drugs primarily affect serotonin receptors, leading to distorted perceptions, enhanced sensory experiences, and profound alterations in consciousness. Many individuals describe spiritual or mystical experiences, while others experience intense anxiety, paranoia, or psychotic-like symptoms, often referred to as a bad trip. And if you might remember for our schizophrenia spectrum lecture, schizophrenia spectrum also is impacting serotonin. So in some way, using these hallucinogens can mimic the symptoms of schizophrenia. So just kind of keep that in mind. And a unique risk associated with the classic hallucinogens is hallucinogen persisting perception disorder, or HPPD. That's a condition where individuals experience flashbacks, visual disturbances, and perceptual distortions long after stopping use. And while some effects of these substances will fade after intoxication, hallucinogen persisting perception disorder can last for weeks, months, or even years, significantly affecting daily functioning. So the general rule of thumb is the longer a person gets away from the substance use, the healthier their brain becomes, the less they have symptoms. This is the one exception to the rule. Hallucinogen persisting perception disorder, it's in the name, it persists. So it's important for counselors to recognize that LSD and psilocybin are currently being researched for therapeutic potential for treating PTSD, depression, and end-of-life anxiety. And I know we talked about some of that already in previous lectures, but unsupervised use can lead to severe psychological distress, paranoia, and even psychosis in vulnerable individuals, particularly those with underlying schizophrenia or mood disorders. Counselors should assess for motivations behind use, history of prior bad trips, and any long-term perceptual disturbances that may require clinical intervention. And then the second class is called dissociative drugs, and those are drugs like PCP or angel dust, also ketamine, also called Special K, DXM or dextromethorphan, which is found in cough syrup, and nitrous oxide or laughing gas. And they work by blocking NMDA receptors, leading to out-of-body experiences, detachment from reality, and altered perceptions of time and space. Unlike classic hallucinogens, which primarily distort sensory input, dissociatives can create a profound sense of detachment from the self and surroundings, making users feel as though they're observing themselves from an outside body. At high doses, dissociative drugs can cause extreme confusion, aggression, and erratic behavior. PCP in particular is notorious for inducing violent outbursts, paranoia, and a sense of invulnerability, making it one of the most dangerous hallucinogens in terms of risk for self-harm or harm to others. PCP intoxication can result in unpredictable aggression, psychotic symptoms, and extreme agitation, often requiring medical intervention or sedation in emergency settings. Counselors should assess for a history of dissociative drug use, particularly in individuals who report persistent dissociation, paranoia, or mood instability. And again, while ketamine is being explored for use in treatment-resistant depression, recreational use carries significant risks, including bladder damage and cognitive impairments. And clients who misuse cough syrup or nitrous oxide should also be assessed for underlying trauma or anxiety disorders, as these substances are often used to escape or numb emotions. And opioids are one of the most addictive and deadly substances. Used both medicinally for pain relief and recreationally for their euphoric effects, this class of drugs includes heroin, prescription painkillers like oxycodone, hydrocodone, morphine, fentanyl, and codeine. And then there's the synthetic opioids like tramadol and carfentanil. While opioids are highly effective at relieving pain, their addictive potential and overdose risks make them a major concern in both medical and illicit use settings. The opioid epidemic, largely driven by prescription misuse, fentanyl contamination, and heroin availability, has led to a public health crisis with rising overdose deaths. So opioids work by binding to the mu-opioid receptor in the brain, producing pain relief, intense euphoria, and sedation. At high doses, opioids can severely depress respiration, leading to fatal overdoses, particularly with fentanyl-laced substances. And fentanyl is a synthetic opioid 50 times stronger than heroin. Carfentanil is an animal tranquilizer 100 times more potent than fentanyl, and that significantly increased overdose deaths. Individuals using street drugs may unknowingly ingest fentanyl-laced heroin, cocaine, or counterfeit pills, dramatically increasing the risk of accidental overdose. So unlike alcohol and benzodiazepine withdrawal, which we haven't really talked about yet, opioid withdrawal is typically not fatal, but it is intensely painful and debilitating. Sometimes people feel like they're going to die, even though they're not going to die. Symptoms include severe body aches, nausea, vomiting, diarrhea, excessive sweating, chills, insomnia, anxiety, intense cravings. Just think of the worst flu or the worst bout of COVID that you've ever been through. The extreme discomfort of withdrawal is one of the most primary reasons why individuals relapse, as using again provides immediate relief from withdrawal symptoms. So think of the worst flu you've ever had. And if you could take a pill to make it go away, would you? That's a reason why people relapse. So for mental health counselors, understanding harm reduction strategies and medication-assisted treatment is essential. Opioid overdoses are reversible with naloxone, or the brand name Narcan. It's a life-saving medication that blocks opioid receptors in the brain and restores breathing. Counselors working with clients at risk for overdose should advocate for access to Narcan and educate both clients and their families on its use. Additionally, medication-assisted treatment with methadone, buprenorphine, Suboxone, naltrexone, Vivitrol has been shown to significantly improve recovery outcomes by reducing withdrawal symptoms, cravings, and relapse risk. Clients may also prevent with co-occurring trauma, chronic pain, mental health conditions that contribute to opioid use. Counselors should take a non-judgmental, trauma-informed approach, recognizing that for many individuals, opioid use began as a means of coping with pain, whether physical, emotional, or both. Encouraging harm reduction strategies like MAT and addressing underlying psychological distress are key components of effective opioid use disorder treatment. Sedative, hypnotics, and anxiolytics are central nervous system depressants like alcohol. They primarily are used to reduce anxiety, induce sleep, and promote relaxation. This category includes benzodiazepines like Xanax, Klonopin, Valium, Ativan. There's barbiturates like phenobarbital and secobarbital. And non-benzodiazepine sedatives like the Z drugs are Ambien, Lunesta, Sonata. And while these medications can be highly effective when used as prescribed, they also have a high risk of dependence, tolerance, and overdose, especially when combined with other depressants like alcohol or opioids. At therapeutic doses, sedatives calm the nervous system, reduce muscle tension, and promote sleep. However, at higher doses with prolonged use, they can cause memory impairment, poor coordination, confusion, and extreme drowsiness. One of the most dangerous risks associated with sedatives, especially benzodiazepines and barbiturates, is there potential for overdose, which can lead to respiratory depression, coma, and death. And the risk of fatal overdose increases significantly when these drugs are combined with alcohol, opioids, or other depressants. So when we're looking at adding alcohol, opioids, other depressants, benzodiazepines together, we get a math equation that doesn't look like 1 + 1 = 2. It looks like 1 + 1 = 10. So we have to be really careful. And unlike opioid withdrawal from benzodiazepines and barbiturates can be fatal. So again, we're going to remember alcohol, benzodiazepines, barbiturates. Those are the possible fatal withdrawals. Symptoms of withdrawal can include severe anxiety, panic attacks, hallucinations, tremors, psychosis, and seizures. So basically the opposite of what it's used to treat. Long-term users may experience protracted withdrawal symptoms lasting weeks or months, including insomnia, mood instability, and cognitive issues. Because of the life-threatening nature of withdrawal, individuals attempting to quit these substances should undergo a medically supervised detoxification process to prevent severe complications. And mental health counselors must be aware that long-term use of benzodiazepines carries a high risk of dependency, even when taken as prescribed. Clients with anxiety disorders, PTSD, or insomnia may become reliant on these medications for emotional regulation and sleep, making discontinuation particularly challenging. Counselors should work collaboratively with medical providers to explore tapering strategies, alternative anxiety treatments like CBT, DBT, and mindfulness practices, and non-addictive medication options. Additionally, clients should be educated on the risks of combining sedatives with other substances and the importance of seeking medical supervision when discontinuing use. Given the high potential for misuse, it's crucial for counselors to assess whether a client's sedative use is part of a larger substance use disorder, a coping mechanism for unresolved trauma, or result of long-term medical treatment for anxiety and sleep disorders. A trauma-informed approach that provides safe alternatives for anxiety management and structured support for tapering can greatly enhance treatment outcomes. And the last substance type that I'm going to talk about today is inhalants. These are volatile substances that produce psychoactive effects when inhaled, often for their short-lived euphoria and intoxicating effects. Unlike most other substances of abuse, inhalants are widely available in household products, making them easily accessible, especially to adolescents and individuals in low-income communities. Common inhalants include gasoline, paint thinner, glue, aerosol sprays. Here's nitrous oxide again, aka laughing gas. You might remember it from when I was talking about hallucinogens. And industrial solvents, so think paint thinner. The immediate effects of inhalant use include dizziness, lightheadedness, euphoria, and in some cases, hallucinations. However, these effects are short-lived, leading users to inhale repeatedly in a single session, which increases the risk of oxygen deprivation, unconsciousness, and sudden death. Long-term inhalant use is often associated with severe neurological damage, cognitive impairment, and organ damage. And one of the most serious risks of inhalant use is sudden sniffing death syndrome, where single use can trigger a fatal heart failure due to acute cardiac arrhythmia. So because inhalants are cheap, legal, and easily accessible, they're most commonly abused by adolescents, particularly in underserved communities where other substances may be harder to obtain. Counselors should be aware that inhalant users may not recognize the severity of their substance use, as inhalants lack the same stigma as drugs like opioids or stimulants do. Screening for inhalant use is critical, as it may be underreported due to shame or lack of awareness about its dangers. Additionally, inhalant use often co-occurs with trauma, neglect, or other environmental stressors, making it important for counselors to take a compassionate, non-judgmental approach and explore alternative coping strategies, educational interventions, and community-based support for at-risk individuals. And if cognitive impairment is suspected due to chronic use, neuropsychological evaluation and long-term support for cognitive rehabilitation may be necessary. Okay, so now that we've got all those substances out of the way, let's talk about challenges in differential diagnosis. So diagnosing addiction isn't always straightforward. It seems like it, right? Count the number of symptoms, bam, you got a mild, moderate, or severe. But as substance use disorders often overlap with mental health symptoms, it makes it a little bit difficult to distinguish between withdrawal effects, co-occurring psychiatric conditions, and primary mental health disorders. Substance use withdrawal symptoms can closely resemble mental illness, leading to potential misdiagnosis and inappropriate treatment. And not just the withdrawal, but active intoxication can also look like mental illness. So, for example, let's think about a stimulant withdrawal. And again, you want to think about withdrawal symptoms sort of being the opposite of what the substance might look like in acute intoxication. So, stimulants generally make you feel like you're on top of the world. The withdrawal is going to mimic depression, causing extreme fatigue, anhedonia, and low motivation. Similarly, alcohol withdrawal can induce anxiety, hallucinations, and even seizures, which could be mistaken for an anxiety disorder or a psychotic episode. So, without considering the possibility of recent substance use or withdrawal, individuals may be misdiagnosed with primary mood or anxiety disorders rather than receiving the proper stabilization for substance withdrawal. Another major challenge is the high prevalence of co occurring disorders or dual diagnosis, which dual diagnosis is an old term, which basically means we have this diagnosis and we have this other diagnosis. So there's two. Co occurring disorders talks about there being multiple. So there doesn't have to be just two, there could be three or four or five. And this is where individuals struggle with both a substance use disorder and a mental health condition, or multiple substance use disorders and multiple mental health conditions. And this often raises the question, which came first? It's the chicken or the egg? Did an individual with depression start drinking to self medicate, or did chronic alcohol use lead to depressive symptoms? Similarly, somebody with ADHD who misuses stimulants may be mistakenly perceived as having a stimulant use disorder, when in reality, they may have been attempting to manage their symptoms with non prescribed medication. The risk of misdiagnosis is particularly high in individuals with bipolar disorder, psychotic disorders, or trauma histories. A person in opioid or stimulant withdrawal may appear severely depressed, leading to prescription of antidepressants when what they actually need is withdrawal stabilization and substance use treatment. Likewise, a person experiencing mania may engage in excessive drug use, impulsive behaviors, and risky decisions, raising the question of whether the substance use is a symptom of the bipolar or a co occurring addiction. So, understanding addiction requires us to look beyond surface level behaviors and ask why people turn to substances or compulsive behaviors in the first place. And one of the most well established explanations is that trauma can be a key driver of addiction, rewiring the brain, altering emotional regulation, and influencing coping strategies. Trauma doesn't just impact the mind, it changes the body, the nervous system, and the person's entire way of interacting with the world. When we view addiction through a trauma informed lens, we recognize that substance use is often not about seeking pleasure, but rather about seeking relief, a way to manage overwhelming emotions, memories, and physiological responses that feel unbearable. So, from a biological standpoint, trauma and addiction share overlapping pathways in the brain, particularly that hypothalamic pituitary adrenal axis, or the HPA axis. The HPA axis, which regulates our body's stress response, is often dysregulated in people with PTSD and chronic trauma histories. In response to trauma, the HPA axis becomes hyperactive, leading to increased cortisol production, heightened arousal, and persistent fight or flight state. Over time, the brain becomes hypersensitive to stress, making everyday situations feel like a threat. And this is where substances come in. Drugs and alcohol artificially suppress the HPA axis, right? Some are central nervous system depressants, temporarily numbing the stress response and providing a sense of calm. Substances like opioids, benzodiazepines, and alcohol act as powerful down-regulators, giving trauma survivors relief from hypervigilance, anxiety, and intrusive memories. Meanwhile, stimulants like cocaine or methamphetamine can help combat the fatigue and emotional numbness that come from chronic stress. The result? A reinforced cycle of substance use where the brain learns that chemicals provide a faster, more reliable sense of relief than any natural coping mechanism. And the supersensitivity model explains why some people seem biologically primed for addiction. Genetic vulnerability plays a role in how trauma impacts the brain, with some individuals having heightened dopamine sensitivity or altered stress responses that make them more prone to developing compulsive substance use patterns. If a person is genetically predisposed to an overactive stress response, combined with early exposure to trauma, their neurobiology may make them highly vulnerable to addiction, even with relatively limited exposure to substances. So that's the biology. Beyond neurobiology, trauma shapes the way that people psychologically process their experiences and interact in relationships, both of which can contribute to addiction. One of the most well-known psychological models is the self-medication hypothesis, which suggests that people use substances as a way to manage trauma symptoms. For many individuals, drug and alcohol serve as a way to dull that emotional pain, silence intrusive memories, or regain a sense of control. For example, somebody with childhood trauma might use alcohol to suppress hypervigilance and social anxiety, while another person might use stimulants to counteract dissociation and numbness. And the problem, of course, is that while substances provide short-term relief, they worsen symptoms in the long run, reinforcing dependence and increasing emotional instability. Attachment theory provides another crucial lens for understanding addiction, particularly in people with early relational trauma. Our first relationships, especially with caregivers, shape how we experience safety, connection, and self-worth. When children grow up in environments where their needs are inconsistently met, ignored, or responded to with hostility, They develop insecure attachment styles, leading to difficulty regulating emotions and forming healthy relationships. People with attachment trauma often turn to substances as a substitute for emotional connection, using drugs or compulsive behaviors to fill the void left by neglect, abandonment, or abuse. And this is why addiction is often referred to as a relationship disorder, because at its core, it's about unmet emotional needs and disrupted attachments. And it makes sense, right? We know what alcohol is going to do. We know the effects that it's going to have on us. We know what will happen if we drink one. We know what will happen if we drink 10. In some ways, it's predictable and safe. In ways that relationships of our past or present may not be. And biology and psychology alone don't tell the full story. Social and environmental factors play a massive role in addiction risk, particularly when we look at adverse childhood experiences or ACEs and broader systemic factors like poverty, racism, and community violence. ACEs such as physical or emotional abuse, neglect, domestic violence, or parental substance use significantly increase the likelihood of developing addiction. Research has shown that the more ACEs a person experiences, the greater their risk of substance use disorders, mental health struggles, and chronic physical illness. These early experiences wire the brain to expect stress and chaos, making people more likely to seek substances as a coping mechanism. Beyond individual trauma, community trauma, and systemic oppression, community trauma and systemic oppression shape addiction patterns in entire populations. Neighborhoods with high levels of violence, poverty, and lack of access to healthcare may have significantly higher rates of substance use disorder. When people grow up in environments where stress is constant, opportunities are limited, and survival feels like the priority, addiction becomes not just about an individual issue, but a collective response to adversity. Consider communities that experience generational trauma, such as indigenous populations, communities affected by mass incarceration, or historically oppressed groups. These populations often face higher addiction rates not because of individual choices, but because of larger societal structures that create chronic stress and limit access to support and resources. Recognizing the role of systemic oppression in addiction is essential if we truly want to take a trauma-informed approach to treatment. So looking at addiction through just one lens, whether it's biological, psychological, or social, leaves us with an incomplete picture. All three interact in a complex web, making it essential to take an integrative, trauma-informed approach to understanding addiction. So a person who develops an opioid addiction, for example, might have a genetic predisposition, so biological vulnerability, a history of childhood neglect, psychological attachment wounds, and grown up in a high-stress, under-resourced environment or social disadvantage. If we only focus on one piece of the puzzle, we miss opportunities for meaningful intervention. A truly effective treatment plan must address all three areas, helping individuals regulate their nervous system, process trauma, and develop healthier coping skills, while also working to change the broader social structures that contribute to addiction risk. So in the next section, we're going to take this understanding of trauma and addiction and explore how it plays out in diagnostic frameworks like the DSM-5 and ICD-11. So keep this question in mind as we move forward. If trauma and addiction are so deeply connected, how should this influence the way that we diagnose and treat substance use disorders? Traditional diagnostic models for substance use and addiction tend to focus primarily on behavioral symptoms, such as how frequently a person uses, whether they experience withdrawal, and the impact of their substance use on daily life. While these criteria are essential, they often fail to consider the underlying trauma that may be driving the addiction in the first place. Many individuals struggling with addiction are not simply making impulsive choices or seeking pleasure. They're attempting to regulate overwhelming emotions, intrusive memories, or chronic hyperarousal caused by past trauma. When a diagnostic model overlooks this context, it can lead to misunderstandings about the root causes of addiction and limit the effectiveness of treatment plans. And one major limitation of traditional diagnostic frameworks is their tendency to misattribute trauma responses to personality disorders or other mental health conditions without acknowledging the role of past experiences. So for example, a person with both PTSD and substance use disorder may exhibit emotional instability, impulsivity, and intense fear of abandonment, which could be misdiagnosed as borderline personality disorder rather than a trauma-based response. And this is problematic because the treatment approaches for borderline personality disorder and PTSD differ significantly. Misdiagnosis can lead to inappropriate interventions that fail to address the underlying trauma and may even reinforce feelings of shame or self-blame. Similarly, somebody experiencing dissociation and emotional numbing from complex trauma might be seen as unmotivated or disengaged in treatment, when in reality, their brain is protecting them from further overwhelm. To provide a more accurate and effective diagnosis, clinicians must adopt an integrated trauma-informed approach to assessment. One crucial step in this process is routinely screening for trauma histories when evaluating individuals for substance use disorders. And this means going beyond standard substance use questionnaires to ask how substance use relates to coping, stress management, or past adverse experiences. When trauma is acknowledged early in the diagnostic process, treatment plans can be tailored to address both substance use and the unresolved trauma driving it, rather than just focusing on symptom reduction. So, when treating substance use disorders through a trauma informed lens, it's essential to recognize that traditional addiction treatments like behavioral counseling and abstinence based models often fail to address the underlying trauma that fuels addiction. The root cause of substance use is usually unresolved trauma, not always, but usually. And simply focusing on stopping the drug or alcohol use without providing tools for emotional regulation, distress tolerance, and trauma healing sets people up for relapse. Effective treatment must integrate trauma and addiction recovery together, helping individuals process past experience, regulate their nervous system, and develop healthy coping mechanisms beyond substance use. So, some treatment options may include cognitive behavioral therapies, and they're one of the most widely used treatments for PTSD and addiction, but standard CBT approaches often need to be adapted to address trauma. So that's where TF-CBT, or trauma-focused CBT, incorporates principles of gradual exposure and cognitive restructuring to help individuals process traumatic memories while learning healthier coping strategies. And then there's prolonged exposure therapy. I know I talked about this one in the trauma lecture too, but it's another evidence-based treatment that specifically targets trauma-related avoidance behaviors, a common driver of substance use. And for individuals who struggle with severe emotional dysregulation, dialectical behavior therapy, or DBT, is an essential treatment option. Many trauma survivors have difficulty managing intense emotions, leading to impulsivity, self-harm, and substance use as an emotional escape. And while cognitive therapies address thought patterns and behaviors, many trauma survivors benefit from body-based or somatic approaches that help them process trauma on a deeper level. So think trauma isn't just stored in the mind, it's also stored in the body. And for many individuals, talk therapy isn't enough. So that's where EMDR, or eye movement desensitization and reprocessing, comes in. And it's one of the most well-researched trauma treatments and has been shown to be effective for addiction too. Art therapy and other expressive interventions provide another powerful way to process trauma without relying solely on verbal expression. Many individuals with trauma and addiction struggle with dissociation, or a psychological response where they feel disconnected from their emotions, their body, or reality. Expressive therapies, including the visual arts, music therapy, drama therapy, or movement-based approaches, can help reintegrate fragmented experiences, reducing anxiety, and provide a healthy outlet for emotional expression. For individuals who find it difficult to verbalize their trauma, art therapy works to provide nonverbal pathways to healing, allowing people to explore emotions and memories in a way that feels safe and manageable. And then beyond individual therapy, community support, peer-based recovery programs, and group therapy is vital as part of long-term addiction recovery, especially for trauma survivors. Traditional 12-step programs such as Alcoholics Anonymous and Narcotics Anonymous have provided a lifeline for many individuals, offering structured support, accountability, and a sense of belonging. However, these programs are not always trauma sensitive, and some individuals, especially those with religious trauma or have issues with powerlessness or difficulty with the hierarchical structures, may struggle with the spiritual framework of the 12-step model. For individuals who prefer an alternative to that peer support model, there are several non-religious and trauma-informed recovery options. So this would include SPART recovery, which is science-based. It's based on a cognitive behavioral approach that focuses on self-empowerment, coping skills, and relapse prevention without requiring that belief in a higher power. There's Dharma recovery, or also known as refuge recovery, and that's a Buddhist-inspired approach that integrates mindfulness, meditation, and non-attachment principles to addiction recovery, but they don't really push the Buddhism. It's just sort of rooted in Buddhism practices. And then there's Life Ring, which is a totally secular alternative that focuses on self-reliance, personal empowerment, and peer support without those spiritual components. So these options allow individuals to choose a recovery model that aligns with their personal beliefs and healing needs, increasing their chances of long-term success. For trauma survivors, feeling safe and heard with a community support is crucial, and offering multiple pathways to recovery ensures that more people can find a structure that works for them. So wrapping up, understanding addiction and substance use disorders requires more than just identifying patterns of drug or alcohol use or gambling or compulsive behaviors. It involves recognizing the biopsychosocial factors that contribute to compulsive substance use and the impact of trauma on brain function, behavior, and emotional regulation. The DSM-5-TR provides a structured framework for diagnosing substance use disorders, emphasizing not just substance use itself, but the ways in which it disrupts a person's life, relationships, and overall well-being. The DSM-5-TR criteria for substance use disorders focuses on 4 key domains: loss of control, social impairment, risky use, and physiological dependence or tolerance and withdrawal. A person must meet at least 2 out of 11 possible criteria to receive a diagnosis, with severity classifications ranging from mild, 2 to 3 symptoms, moderate, 4 to 5 symptoms, and severe, 6 or more symptoms. And one of the key limitations of traditional diagnostic approaches is that they often prioritize observable behavior patterns without accounting for the underlying trauma that may be driving the substance use. Many individuals with addiction are not simply making poor choices, they're using substances as a means of coping with emotional distress, trauma, or neurological dysregulation caused by adverse life experiences. This has led to frequent misdiagnoses. For example, individuals with PTSD who use substances to manage symptoms like flashback, emotional dysregulation, or hyperarousal may be mistakenly diagnosed with borderline personality disorder. This highlights the need for trauma-informed diagnostic practices to integrate screening for trauma histories, co-occurring mental health disorders, and the functional role of substances in a person's life. And beyond substance-related disorders, the DSM-5-TR also includes behavioral addictions, though currently only gambling disorder is fully recognized. Other compulsive behaviors such as sex addiction, internet addiction, and compulsive shopping have not been included in the DSM-5-TR, despite evidence suggesting that they engage in the same reward system in the brain as substance use disorders. The exclusion of these conditions raises an important question about how addiction is defined and whether diagnostic models should expand to recognize a broader spectrum of compulsive behaviors. While the DSM-5-TR remains the primary diagnostic manual in the United States, it's important to compare it with the ICD-11, which offers a slightly different framework for diagnosing addiction. Unlike the DSM, which classifies substance use disorders on behavioral patterns and impairment, the ICD-11 distinguishes between harmful substance use and substance dependence. Additionally, the ICD-11 includes compulsive sexual behavior disorder and gaming disorder, reflecting a broader approach to recognizing behavioral addictions. A trauma-informed approach to diagnosing substance use disorders requires looking beyond symptoms and asking what happened to this person rather than what's wrong with them. By integrating biological, psychological, and social perspectives, clinicians can better understand the root causes of addiction, reduce stigma, and develop treatment plans that address both substance use and the trauma that fuels it. Thanks so much for hanging out with me today. I know that we covered a lot. If you have any questions, please let me know. I am happy to jump in and talk more about this at any time. Thanks.